Thank you very much, Dr. Kai, and congratulations to my very dear friend Narendra for putting together this wonderful meeting together. I think me speaking on this subject is a little bit of an oxymoron. So when I got introduced to this concept of the robotic about 12, 14 months ago, the real question was yes or no, and we decided to delve into this issue. We do have a high volume practice, and one of the key things that a lot of people keep asking me all the time is, why get into technology at this stage of my life? I'd like to anecdotally mention very, very briefly that when I started doing knee replacements in '83, and when I came back from England in '85, the choice of implants was used to get one femur. That was the only one size that you used to get of the femur, and you used to get one polyethylene tibial component, and we matched the bone cuts to the size of the femur that we have got available. So we have come a long way to defining technology in its present avatar. So I just thought, taking on from where Costa left off, what is robotic surgery? How does it make a difference in knee replacement? I'd like to start by saying that robotic innovation or its intervention in knee replacement surgery is not a marketing tool. And I went through a considerable amount of reading and research into preparing this presentation, and I was very pleasantly surprised that we were actually on the right path. How do you move this forward? Which one do you say? This one you want to use. Oh, this one? Yeah. No, I just want to move it forward. How do I move this? This one? Okay, right. So I think we're on the threshold of a epidemic of osteoarthritis, and almost about 1 million patients are there in India, and less than 1.2% of these patients actually get operated. And it's these are global figures for India. About by 2025, there'll be almost 6 million patients who would be suffering from osteoarthritis. A large percentage of our population has osteopenia, osteoporosis, which impacts bone quality, fixation issues. And approximately 9% of all patients are revised, and this is the Australian data registry in the recent years. And interestingly enough, there is a bias, increasingly bias, yet another bias towards unicompartment surgery favoring this procedure. If you look at the Oxford group, they would recommend almost 70% of all knees undergoing replacement surgery should be uni. Not sure that is a statistic that I would actually agree with. In the Indian context, it's believed almost 1/5 of all knees may be treated adequately by unicompartment surgery. Again, a statement that I would put a bit of a question mark on. And I think the one factor that each of the presenters has already put to the audience is there is a proportion of patients, no matter how well you do your surgery, who are going to be dissatisfied. Dr. Kepa alluded to it, Dr. Vaidya alluded to it. So I think this is a given. I think we are in a disadvantageous situation compared to our hip colleagues, where less than 3 to 5% are dissatisfied. So it begs the question, what is the current status of total knee replacement? And when you look at Phil Noble's study and you look at Peter Sharkey and Tom Ferring's work, they all mention that revision is an integral part of knee replacement surgery. And worryingly enough, almost half of these early revisions happen within 2 years of the index surgery. And why do they fail? They fail because of fixation failures. You're not cementing them well. Instability. This is actually a Pandora's box, and malalignment. So let's look at the instability and the malalignment, because these are issues that are technical. Fixation is because of poor cementation or using implants that do not have inherent fixation modalities that are available. Which brings us to the afternoon and tomorrow's issue, the Navio. What are the features, what are the benefits of this particular technology? This is basically reproducible. It's not, as you've heard from the earlier speakers, it's not a true robot. It's a semi-automated robot. But it helps to preserve bone. It helps you to understand soft tissues. It has a mobile cart, so it doesn't actually occupy half of your operating room. And it can be modulated. You can be trained to it. And again, like one of the earlier slides showed, it takes approximately about 10 procedures to get the hang of it, or 12 to 15 to get comfortable, and 20 for it to be a part of your armamentarium. So this allows for both soft tissue and bone resection options, and it is well controllable within the ambit of what you're trying to achieve, and you can do your fine-tuning at the end of your procedure as well. It also supports various implants, both partial and total, so you can have a choice of doing a Legion or a Navio or even a BCS, and you have the option of using a unicompartment or a patellofemoral device. So how does it benefit the patient? I think the one thing that certainly stands out in our experience, particularly on the uni side, is that it is almost pain-free. We have now started doing almost all of our unicompartment surgeries as daycare surgeries. The patient comes in the morning, gets his surgery done by 7:30. By 4 o'clock, he's back home. The incisions are relatively smaller, and the patient experience, certainly with the uni, has been particularly good. It is consistent, it's accurate, it's predictable. You can teach your fellows and residents on the finer concepts of bone resection, and it is definitely a differentiator, and it will certainly help to enhance the experience of the patient and give predictable outcomes that can be validated and numerized. I would like to, in the last column over here, I would like to make a point that this is not a marketing tool. It is a tool that helps patients, and I think we should address it as such. And there's enough evidence now, and if you look at the last 2 or 3 years of certainly the leading arthroplasty journals of arthroplasty, journal of knee surgery, JBJS, there is increasing evidence of a positive report coming out in favor of the robotic system, and be that as it may. And Jess Lawner has been one of the sort of front runners for this. He wrote this article in 2015, where he validated his cadaveric study outcomes, and this was reported in the CORR. Another study from Gonzalez and his group in 2014, preliminary results of the uni, and they reported excellent outcomes. So typically in the context of the robotic options, currently in the United States, it accounts for approximately about 15% of the unicompartment, likely to grow to 35% over the next few years, because it has proven that it shows improved component alignment, fewer outliers. And the real question is, does this enhanced precision efficiency make robotics more cost-effective, and does it assist in time management? So when you look at alignment, the major reason why unis fail, and we'll split this up into a uni talk and a total talk. In uni, the most important consideration is alignment, and most of the failures that happen, aseptic failures we're talking about, is malalignment. And anything between 40 to 60% of cases done manually or conventionally show an outlier beyond 2 degrees. And hence, this has been advocated as an indication for robotic options with predictable bone preparation and soft tissue balancing. And these are the 2 articles in GOA as early as 2006, and Greg Keen's group in Adelaide in 2006 again. So when you look at the effective robotic assistance, the root mean square was significantly reduced. Again, just Lawner's group in 2010, he's done a lot of work on this, Hansen's group in 2014 found significantly improved femoral component position. However, in his experience, in his report, there was no changes in the tibial component position. The other thing which is very interesting is patients who are done robotically have an insert usually of 8 to 9 millimeters versus a much higher thickness of insert, which would be indicative of the fact that an excessive amount of tibial resection has been done. So the median score, the pain score is considerably less, and this has been our experience. This has been really sort of very welcome in the patients. The forgotten joint score was also much higher in the robotic group. But we do not really have current long-term survivorship data for the simple reason that it's not been around for that long length of time. When you look at the coronal plane alignment, malalignment, we know Sharkey's work and Schroer's work. Now, the real sort of question is, what do you call acceptable malalignment? And I'd like to say that when I was reviewing literature, it's very interesting. It's not the plus minus 0 to 3 degrees malalignment. In fact, there are articles that allude to the fact that patients who had beyond 3 degrees of malalignment actually had lesser revision rates compared to the conventional 0 to 3. So really, what are we aiming at? So we want an alignment which is within 1 to 2 degrees of all planes, the rotational, the coronal, and the sagittal plane. And Song, who's again done a fair amount of reporting on this front, has alluded to the fact that there's no overall difference in the coronal alignment, but there's better gap balancing. When we look at function and survivorship, like I said, there's no long-term data available, but the short-term, the SF36 is certainly better in the robotic group. And survivorship at 5 to 10 years, which is really the most recent evidence of outcomes, has been comparable. So if everything is good, what are the downsides of the robotic? Are there any? So the first thing, which is obvious in a cost-constrained market, which is what the medical industry is facing all over the world, is the cost is expensive. There are consumable costs and maintenance costs. Then there's the learning curve, which, as I said, takes about 10 to 12 cases, and most people will be comfortable in that. It does not have radiation options, so you cut down on that. There is the risk of pin tract infections. There have been reports of fractures and injuries to the medial collateral ligament, the patellar tendon, and neurovascular injury, one of which happened to come our way, where this was attempted, and there was a neurovascular injury that required a popliteal artery reconstruction. So this, again, this slide you've already seen, 6 to 8. I would put this a little higher than this. Certainly in our own hands, it took us about 10 cases before we got comfortable. And again, we do review, when we did review of literature, when you compare it to conventional sawbone surgery, the robotic does seem to be less, but we need more research and time to be able to compare the outcomes in implant survivorship. The most recent article, the 18 edition of Journal of Arthroplasty that Dr. Kaper also alluded to, has some excellent references to robotics. And this was a symposium on robotics, the ARCUS symposium reported by Brian Parsley, where he alludes to the fact that there's optimal alignment, size, and placement, and also possibly in the realm of customizing implants. I think there's growing interest in the role of advocating customized implants for each individual patient, and there are certain companies that are actually making this. So will this stand the test of time? Hard to say at this point of time, but the indications are that most probably it will. So coming back now to the Navio, and I think you'll see a lot of this in the, so we'll very quickly run through this. The interesting thing about the Navio is it validates your laxity and soft tissue balance at various stages throughout the case, and you can balance your ligaments both before and after. Dr. Kaper alluded to the fact and his technique where he does his soft tissue releases towards the end of his surgery. We take the opposite position, so I do my soft tissue releases right at the beginning of the surgery. But you can do this any which way. There are several ways to skin the cat. But the interesting thing with the Navio is you can do it either during, before, or after. And for me, the game changer with the Navio, the reason I sort of took a fancy to this is There have been times when you finish your surgery and you stretch it out into extension and you flex it, and it just feels right. And my fellows and my assistants always used to ask me, what exactly do you mean when you say it just feels right? There are no numbers. It's just a gut and it's a tactile feeling that I have in my mind. With the Navio, you can actually show the numbers, that this is the number, and this is really what I mean when I say it feels right. The second point, which I think, again, Dr. Caper alluded to, and I think this is the critical index of a knee replacement. I believe 90% of the 25% who are dissatisfied with your surgery despite having normal knees, x-rays looking really good, 120 degrees of flexion, the main reason for these patients being dissatisfied, I will stick my neck out, is mid-flexion instability. And that's an extremely gray area, and this instability happens anywhere between 30 to 60 to 75 degrees. With the Navio, you can quantify your soft tissue tensions within that range. And again, very right, it's not 0, 60, and 90. It's across the whole range that you need to quantify the soft tissue balance and have it in the sweet spot within the soft tissue envelope. So you can actually get these sort of graphs at the end of your procedure, which will tell you your medial and lateral balance, and you can then tweak your soft tissues to make sure that you get an acceptable alignment. So very quickly, this is a varus knee that we had operated on. So you get the hardware connection and you get a screen which shows up something like that. You select your burr, and again you have the choice of cylindrical burr. Now we use the cylindrical burr almost exclusively. You have various options in terms of your rotational reference. We typically use the transepicondylar axis, have done that for years. I shy away from the posterior condylar axis, particularly in deformed knees and the concomitant posterior condylar hypertrophy. On the tibial side, we use the tibial tubercle axis. But we'll give you, again, a different perspective to this in a minute. You need to make sure both your markers are seen. You then do your checkpoints. These are the checkpoints that you insert into the femur and the tibia. You validate the anatomical landmarks, the tibial malleolus. You get your hip center calibration. You do a preoperative knee motion collection. And then apply varus and valgus stresses so that you get your soft tissue impact at that point in time. At this point, we typically take out the meniscus and the soft tissues, revalidate this so we get a uncluttered range of motion. You do your femoral landmark point collections, knee center, most posterior, lateral, medial, and the anterior notch point. You then map the femur. You do the same thing on the tibia, on the medial side, the lateral side, and the knee center, the tibial tubercle, and then you'll get a map which looks something like that. And then you can do your gap planning. It gives you a pretty good index of the sizes that you may be using. And you can move these around, up and down. You can flex, extend, and you can validate the amount of bone that you would like to resect from the distal femur. And this would obviously change between the medial, varus and the valgus knees. And you can pretty much customize this to your own requirement. You can do the same thing on the tibial side. You can move your implant around. So this is really a very sort of hands-on dynamic modality where you can actually do and place your implants and actually then check in terms of your preoperative status and what you would like to achieve at the end of your procedure. So once you have done your surgery, you can again look at the correctability and see how much flexion, extension, lateral and medial tightness and looseness there is, and then do your soft tissue titration. In terms of placing your femoral guide, we typically recommend that you do it on the most prominent part so you get your good option. This is in those situations where you're doing a cut using a guide. Now, of late, over the last about 10-15 cases, we've actually not been using this. We have been using the distal burring technique, which is certainly more elegant and takes away a lot of the time. But this is some of my earlier slides, so this is what we started off with. On the tibial side, again, you have this option. You can actually move this around. Again, you can use either the slot guide or the burr technique, which actually takes off the islands and proximal tibia. If you are using this, I would recommend you move this a long way medially, because if you don't, the patellar tendon comes in the way and you can transect the tendon. You then have this option again if you're using the manual technique and you're using the slot guides. You have these divots that appear. You go in and drill through this till the purple becomes white, and then you're down to the adequate depth. And then you can do your verification on the tibial bone removal and the femoral bone removal. There's this little device, I call it a mushroom for want of a better word. It gives you a pretty good indicator of what you like. And then at the end of it, you can do your gap balancing, you can stress it, and then you can get a nice even curve on both the sides. And it's this soft tissue alignment which really gives you this happy feeling that you have done the right amount of resection, you have balanced, you have restored the joint line, and you got that tight. Certainly, I'm a CR surgeon, so for me, having a tight medial and a slightly lax lateral joint is really what appeals to me, and you can validate that and get that in the same part. So this is the post-operative X-ray of this patient. We do not like notching the anterior cortex. That's something for me which is in strict no-no, so we tend to anteriorize or flex it by about 2 to 3 degrees, never more than that. So in terms of the tips and pearls, soft tissue release and lateral removal of menisci should be done as part of the exposure. As I said, we remove all osteophytes. Notch point is well proximal, and we want to align it to the femoral component to prevent notching. We rotate the tibial jig to prevent patellar transection. And finally, I would like to make a point that I don't want to suggest that you want to let the machine take over. Cross-check every step and measure all resected bone surfaces. It helps. Just a couple of slides on the valgus side. Again, essentially exactly the same. The only difference being that when you look at the lateral condyle, oftentimes you will not see this, but now with the distal femoral burring technique, that step gets taken care of. But if you're using a slot, the challenge is not being able to find the little divot to put in your lateral hole. So again, I don't think I need to dwell on this. This has been alluded to by the earlier speaker. There are different options like the Mako, and clearly the Navio gives you more flexibility and adaptability. This gives you the option of using several options and systems. It has precision, it makes it flexible, and gives you a certain amount of confidence that you can do this in one of several ways. This is our experience of the first 61. As you can see, most of these were totally. We have also done 14 unis. We had to abort 2 cases because of some technical issues. Our average operating time now is about 47 minutes, and we've been able to achieve optimal alignment in 58 of the 61 cases without having any intraoperative issues. Thank you for your attention.